This is the posse. These, these are the guys who are going to be talking to you the first couple hours. And our approach is going to be a little bit different. And these guys are members of the motility group, the esophageal diseases group, the functional bowel group. They're all important cogs in our wheel. So their names are up here. We will talk about them as they come up in the talk. Okay, whenever I do this, I always start out explaining what esophageal manometry is and how to think of it. This catheter that you're looking at is a high-resolution esophageal manometry catheter. The gold sort of bands here are impedance electrodes. They're used to determine the direction of flow in the esophagus. The copper-colored, those are pressure sensors. They're 36 pressure sensors. They're a centimeter apart. And this is the output. This is a normal peristaltic sequence. It looks daunting to most people, but I want folks to think about this as in this way. If you're looking at this, along the x-axis is time, along the y-axis is position, and up and down is amplitude. So this is a composite of all 36 pressure sensors positioned one behind the next, with the first one in the stomach, the last one in the upper esophageal sphincter. Think of it in this way, right? Like a mountain range. And pressure is altitude, basically. Now take this, we can add color to the pressure profile, and it's beginning to look like that mountain, that range of mountains. Now, what I want you to do to understand what this manometry stuff is think of yourself as flying above the mountain range, okay? And when you do that, or rotate this image up so you're looking down on it, you get this. The top right bar is the upper esophageal sphincter. At the bar below is the lower esophageal sphincter, and that diagonal band of color is the peristaltic pressure wave. Now, bolus, when we look at impedance, we can look at the direction of a bolus. A low impedance means that there's a liquid in the esophagus, and these are two examples of the impedance dropping. One is antegrade, and that is a swallow, and then there's one that's retrograde, and that is a reflux event. Air we can also detect, and in this way you can see that air can be tracked going into the esophagus or out of the esophagus, okay? So we can see a belch. And sometimes we use this for impedance. The magenta color is where the bolus is. And you can see in this case that it's been cleared by the esophagus. Okay, our first case. B is a 38-year-old man. He has a history of substernal burning, excessive belching, particularly after large meals or drinking beer, as he is often doing, and even after coffee. He's had an upper endoscopy that was normal. Biopsies revealed 1 to 2 eosinophils per high-power field, consistent with esophagitis. This is his esophageal manometry, this is his pH study, and he has a pH below 4, which is the cutoff for reflux events, 16.3% of the time. This is positive for acid reflux. So he has reflux. This is what his esophageal manometry looks like. It's very different from that normal one. This one is weak, so it's ineffective esophageal motor function. And this odd-looking thing is actually a belch. Okay. You can see that the lower esophageal sphincter or esophageal gastric junction opens at the bottom. At the top, the upper esophageal sphincter opens, but there's no peristalsis. And then you see where that little arrow is, there's a little increase in pressure, and that's actually gas moving from the stomach up the esophagus and out through the upper sphincter. Now, this is called a transient ileus relaxation, It is triggered by distension of the stomach, stimulation of the pharynx, or CCK, cholecystokinin. It is inhibited by nitric oxide synthase inhibitors, atropine, which is a cholinergic antagonist, and lying down. This is the mechanism, one of the major mechanisms of reflux. And this is how it works. The stomach gets distended. There is a neuron that is activated. It's a vagal neuron. It goes to the brainstem to an area called the nucleus tractus solitarius. Glutamate is released. That activates an interneuron that goes to the dorsal motor nucleus of the vagus. That activates another vagal efferent or motor neuron that goes into the myenteric plexus, into the wall of the esophagus. It stimulates the release of nitric oxide, and that makes the sphincter relax, and you get the belch. So that's the mechanism. We don't use this medication very often. It's Baclofen. Baclofen turns out to be a very effective way to treat reflux. If you look at this, this is really a good randomized, double-blind controlled trial looking at Baclofen's effect. The top two panels are the effect of Baclofen. The bottom two panels are placebo. And you can see that both the number of reflux events and the pH, the number of percentage time that the pH is below 4, they're both improved by the Baclofen. Common side effect, need to be aware of it, makes some people sleepy. If that's the case, it can't be used. Okay, that's our belch. Case 2. ES is a 52-year-old anxious gentleman with an 18-month history of substernal dysphagia, squeezing chest pain, regurgitation of foamy fluid, and undigested food. He had an upper endoscopy that was normal except for seeing some foamy material in there. He had biopsies that revealed 1 to 2 eosinophils per high-powered field, and he had an esophageal manometry. And that esophageal manometry is here. Anybody have an idea what this might be? How about the fellows? Any fellows? What does it look like? So do you see relaxation of the lower esophageal sphincter? Yes or no? Shaking your heads no. Okay. Do you see peristalsis? No. Okay. So if the sphincter doesn't open and there's no peristalsis, that is pretty much diagnostic of what? Somebody speak up. Achalasia. So this, I wasn't entirely sure with this guy, so I gave him some Botox. He got better. And then a few months later, his symptoms came back. So he had a Heller myotomy. And he did really well for a year. And then in a year, he came back, and he was complaining now of frequent repetitive belches. No dysphagia, no chest pain, no heartburn, and no regurgitation. So it doesn't really sound like achalasia, right? His endoscopy was negative. He had a 48-hour pH study that was normal, and he had an esophageal manometry. And this esophageal manometry looks really weird, doesn't it? These aren't swallows. They're something else. And Craig Gluckman is going to tell us what's going on here.
Thanks, Dr. Conklin, and thanks to the course coordinators for giving me an opportunity to speak today. And to answer Dr. Conklin's question, this patient is having repetitive supragastric belches, and I'm going to spend the next 10 minutes explaining exactly what a supragastric belch is. So with the advent of 24-hour pH impedance studies and high-resolution esophageal manometry, we were able to diagnose a new kind of belch that is totally different to the gastric belch, and it was called the supragastric belch. And the reason it was called supragastric is that it's above the stomach. So everything with this belch really happens above the stomach. So If you look at the image, top left, you can see that throughout this belching episode, the lower esophageal sphincter remains closed. The first thing that happens is the diaphragm contracts and moves downwards. This results in a negative intraesophageal or negative intrathoracic pressure. If you go to the image on the top right, you can see that there's a pressure gradient, a pressure differential between the higher atmospheric pressure in the mouth and the pharynx with the lower pressure in the esophagus, and air will move from the mouth and the pharynx, the atmospheric pressure, to the lower pressure within the esophagus. This happens through the open and relaxed upper esophageal sphincter. The air flows down the esophagus, it reaches the lower esophageal sphincter, which has remained closed at all times, and is immediately pushed forcefully back up the esophagus, out through the upper esophageal sphincter and out through the mouth. So as you can see, the stomach is by no way involved in this supragastric belch. So this is a high-resolution esophageal manometry, and they've superimposed in white pH impedance tracing. And this explains the first mechanism of the supragastric belch, where patients are air inhalers. They actually suck air into the esophagus. So the lower esophageal sphincter remains closed throughout. Air moves down the esophagus. From the higher atmospheric pressure in the mouth and the pharynx, it moves into the esophagus, and it is immediately forced back up out the esophagus and out through the mouth. And you can see the red arrows point the direction that the air flows, down the esophagus, reaching the lower esophageal sphincter, and out through the mouth. The white pH impedance tracings show that gas or air causes an increased impedance as it moves down the esophagus. And then as the air or gas moves back up the esophagus, the pH impedance tracing returns to baseline. So this is by far and away the most common mechanism that a supragastric belch occurs, and it's through air inhalation. It is important to remember that this is not a swallow. There's no pharyngeal peristalsis, there is no esophageal peristalsis, and the lower esophageal sphincter, or the EGJ junction, remains closed throughout this belching episode. The second mechanism for a supragastric belch, and this is way less common, is air injection or air pushing. And for this to happen, there needs to be an increase within the pharynx. So whatever can cause increase in the pharynx, be it tense labial closure, laryngeal movements, base of tongue and pharyngeal contraction, anything that causes an increased pressure in the pharynx will push air down the esophagus. It immediately reaches the lower esophageal sphincter and then is pushed back out through the mouth. And once again, this is not a swallow. There's no peristalsis in the esophagus. So side by side, looking at the impedance signatures of these two belches, Dr. Conklin mentioned the gastric belch, where air begins in the stomach and it moves up the esophagus and out through the mouth. That's the image on the left, the pH impedance tracing on the left. Contrast that to the image on the right, where air moves down the esophagus, reaches the closed lower esophageal sphincter, and then is immediately and rapidly pushed back out the esophagus and out through the mouth. And this is the pH impedance tracing of a supragastric belch. What are some of the characteristics of these supragastric belches? We initially believe, and if you look at the top image on the right, this patient has had a reflux episode, and then immediately after that reflux episode, there is a supragastric belch. So what we believe is that maybe this supragastric belch is relieving the uncomfortable sensation of the acid reflux episode. To begin with, supragastric belching is completely voluntary, and the patient has control over this. But after some time, it really becomes out of control, and it almost becomes, like a behavioral disorder. Patients can belch many hundred times per day, and it can really interfere with their quality of life. In the study that I'm going to refer to later, the number of supragastric belches per 24-hour period ranged between 17 and 510 per 24 hours. So you can see how this can really affect quality of life. It can be repetitive, can almost happen, every 5 seconds. What we do know is that supragastric belching does not occur during speech, and nor does it occur during singing. And this is apparent when the patient is in your consulting room, and when they're talking to you, they don't belch. But the minute you as the doctor start talking to the patient and they're distracted, then they go ahead and belch away. So clearly supragastric belching lessened with distraction. And then we know that supragastric belching does not occur during sleep, and you can see the 24-hour pH impedance tracing on the bottom. During the day and waking hours, you can see there's a lot of noise, a lot of activity, a lot of supragastric belches. But during the period of sleep for 6 to 8 hours, it's quiet. There's no supragastric belching. So it's really a chicken and an egg scenario in that, does the acid reflux episode cause the supragastric belch, or does the supragastric belch lead to acid reflux? And we do know that 40 to 50% of patients with acid reflux belch. And we also know that the majority of these belches are supragastric rather than gastric belching. PPIs we know are excellent for acid reflux, but we really don't know their role in treating supragastric belching. And these three questions need to be answered. Does the belch induce a reflux episode? Does the belch actually relieve the reflux episode? Or is the acid reflux actually causing the belch? So if you look at these two pH impedance tracings, we give the two scenarios side by side. So on the left, the patient first has a supragastric belch, and this is immediately followed by an acid reflux. So could you say that this supragastric belch is causing the acid reflux? Unclear. If you look at the pH impedance on the right, the patient has an acid reflux episode, the pH in the distal esophagus is low, and then immediately after, the patient has a supragastric belch. You can almost imagine that in response to this uncomfortable acid reflux sensation, the patient tries to relieve the sensation with a supragastric belch. This study came out of the United Kingdom in 2015, and it was one of the first studies to really look at supragastric belching in terms of its prevalence and its association with acid reflux and esophageal hypomotility. So what they did to begin with is they got 40 healthy volunteers who were all asymptomatic, and all these volunteers underwent 24-hour impedance and high-resolution esophageal manometry. And what they found was that even in these normal asymptomatic patients, they still had supragastric belching with a range of between 0 and 15. So they used the 95th percentile, which was 13 supragastric belches per 24 hours, and they said that in this study, anyone with more than 13 supragastric belches per 24 hours was regarded as excessive. So when looking at the study, they analyzed almost 3,000 patients retrospectively between 2010 and 2013. They looked at all their pH impedance and esophageal manometry recordings. And what they found, and the math works out perfectly, is that 100 patients had supragastric belching episodes. And by that, they mean more than 13 supragastric belches per 24-hour period. And this gave them a prevalence of 3.4%. So with the math being great, 95 patients out of 100, that's 95% presented with typical acid reflux symptoms. 86 out of 100, 86% actually reported excessive belching, but only 50% said that belching was the predominant complaint. So the other 50% thought that, other symptoms they might have had were the predominant complaint. And in this study, what's surprising is that 5% of patients, 5 out of 100, had excessive supragastric belching in isolation, which means they had no associated abdominal pain, acid reflux, or dyspepsia. So if you look at the results, and just briefly, those patients with acid reflux, and what I mean by that, those patients with increased acid exposure time, those patients had more supragastric belching episodes. And secondly, those patients with hypomotility, so an esophagus that contracts ineffectively, those patients also had increased supragastric belching episodes compared to patients with normal motility. And if you look at the bar graph, those patients with normal motility have way less supragastric belching episodes than those with hypomotility. So the conclusion from the study is that patients with acid reflux and esophageal hypomotility have increased supragastric belching episodes. And what they did say that increased belching is rarely a symptom in isolation. It's normally associated with other GI symptoms. So we're able to diagnose supragastric belching. We obviously need to treat it. And originally, and there was excitement in using Baclofen as a way of treating supragastric belching. And this study looked at 12 patients. They were studied for 1 week before Baclofen, and then they were studied for 1 week on Baclofen at a dose of 10 milligrams 3 times a day. Interesting to note, there was only 12 patients in the study, and only 2 of those patients actually complained of supragastric belching as their predominant symptom. We know that Baclofen is a GABA beta agonist, and we know that this is believed to decrease transient lower esophageal sphincter relaxation. But what's interesting to know is that patients with supragastric belching, they don't have transient lower esophageal sphincter relaxation. So it's really unclear if Baclofen does help. Exactly how it's helping, it may actually be a placebo effect. And in the study, you can see that those patients on Baclofen, they had far less supragastric belches than when they weren't on Baclofen. If anyone has ever tried to place a patient on Baclofen, we know that there's many intolerable side effects, sedation, drowsiness, and it's really difficult to up-titrate the dose. So clearly we need other treatment modalities for treating supragastric belching. So what do we have available in our armamentarium? Our psychology colleagues are able to perform cognitive behavioral therapy. We are able to make use of abdominal breathing exercises, maybe as a distraction mechanism to decrease the supragastric belching episodes. But lastly, there's been some excitement in speech therapy. And at this point, I'd like to hand over to my colleague, Lisa Bolden, who's going to explain how speech therapy can help a patient with supragastric belching. Thank you.
Thanks, Craig. So our next speaker, you just heard her name. Lisa is one of our speech and language pathologists. We work very closely with the folks in speech language pathology. She has a new interest in supragastric belching and therapy from the point of view of a speech pathologist. Thank you.
All right, so I bet most of you didn't expect to see a speech pathologist here at a GI conference. So why a speech pathologist? If you think about it, speech pathologists for years have taught people who have had laryngectomies how to speak using esophageal speech. So the thought is, if we can teach someone how to talk using esophageal speech, we can teach them how to not use a supragastric belch. So our program is based on 5 studies that are available in the literature, and if you'd like those references, please contact me after. But we've taken the best of what's available in all the projects that we've read about. There are 4 primary components. The first one is explaining the supragastric belch. We have in speech the advantage of spending about 50 minutes with a patient. So that allows us to go in depth in explanation. We help create self-awareness, we teach rescue breathing, and then most importantly, we help our patients generalize this into the real world. So explaining the supragastric belch, we go through and differentiate the gastric from the supragastric belch. We explain the manometry and impedance results. We solicit the patient's thought as to what the trigger is, and we assign homework to develop a belching diary. Creating self-awareness. So the first step is to be aware of the preceding GI sensation. Is it abdominal distension? Is it pressure in the chest? Is it pressure rising through the chest? We develop self-awareness of injection and inhalation, the 2 methods that you heard about from Dr. Gluckman to get air into the esophagus. And we use the mirror and video. We teach rescue breathing, and this is the hallmark of what is successful for these patients. And we have the patient place their tongue on the alveolar ridge, which is the bony ridge right behind the front teeth. They gently part their lips, and they feel the air flowing in and out. We focus attention on the ribs and abdomen. We focus on the airflow fully filling and fully emptying, and we will have them inspire and expire to a count. This is not with the mouth wide open in this position, because that would just be trading one unusual behavior for another, but rather it's subtle, so it just looks natural. And then we help them generalize, develop a hierarchy of situations based on information from their diaries. We plan and rehearse, and we apply it in the real world. We then rate on a visual analog scale, and I hope, is that large enough for you to see, about how bothered the patient is by their supragastric belching, how bothered others are, how much it impacts them socially and professionally, and how much control they feel they have over their belching. So first case is a 61-year-old female who came to see me. And you can see that her belching was, the preceding event for it was her diagnosis of cancer and the loss of her beloved dog. And what was so moving about her story is that she is a veterinary surgeon. And so the loss of her dog was it was devastating to her. You can see up above the results of her GI testing, and I'll give you a second to look at that. And here she is, and let's see if I hit this, if we'll play. Now you're going to notice that our patient has injection as her primary method, which is a less common method of getting air into the esophagus, so this is a great chance to see that. There we go.
Okay, Linda, go ahead and...
All right, so could you see that? The tight labial seal, the larynx moving up and down. And then this is her after treatment.
So, well, I guess this is a condition that I've been experiencing for approximately 1.5 years now, that has been gradually subsiding with treatment. I'm substantially improved at this point. It's gone from barely tolerable to very tolerable and no longer has a significant effect on my everyday life.
And I really appreciate her willingness to let us use the videos. Not all of our supragastric belching patient will allow that. So her visual analog scale, which is a really good way to assess progress without an invasive procedure. And you can see her initial ratings were high, 325 out of 500. After treatment, 55 out of 500. So again, 325, 55. So good improvement there. And that's what we can offer in speech therapy for your patients with supragastric belching. Thank you.
Thanks, that was great. Show of hands, how many of you have seen this in your clinic and wondered what the heck to do? I'm assuming everybody, right? Yeah. All right, that was great. Next case is I'll present, 23-year-old college student with a history of regurgitation into the mouth during and after meals. No nausea, retching, dysphagia, heartburn, cough, or weight loss. Endoscopy is normal. Upper GI is normal. And this is the esophageal manometry. Now, we showed you what's normal, and this one certainly has normal peristalsis, but there's something else happening here. There's a big pressure that's going up the esophagus, starts in the stomach and goes up the esophagus before the swallow happens. And remember I said we could watch where the bolus is going with this magenta. So there's the material that's in the stomach is moving up with that positive pressure wave. Lisa, you're up. What in the heck is this?
You know, it sounds like this patient truly has regurgitation because there's...
So, come on up here. There you go.
Since there's no preceding symptoms of retching or nausea, and, you know, based on clinical history alone, you might think in clinic, oh, does this patient have really bad reflux or something else? But I think the esophageal manometry really helped to clarify that this is consistent with rumination syndrome, which I will talk about in the next 10 minutes. So we're going to talk about the epidemiology, pathophysiology, clinical symptoms, diagnosis, and treatment for rumination syndrome. The epidemiology for rumination syndrome is not totally clear. We don't really have a great idea of the true incidence and prevalence, but in the literature, the prevalence has been reported to be somewhere between 0.8% to 10.6% in community samples. We also know in certain patient populations, like patients with eating disorders or fibromyalgia, that prevalence can be as high as 7 to 8%. And historically, rumination syndrome was described more in children or in adults with developmental delay, although now it's really recognized as a clinical disorder unrelated to mental status or age. So the pathogenesis for rumination syndrome is also not completely understood, but this is kind of an overview of what we think is going on. We really think that rumination syndrome is a habit that the body kind of forms in relation to food. So I want you to focus your attention to the middle of the slide there under the primary pathway. And you can see basically after the patient eats food, they usually get some sort of premonitory urge. So they usually feel some sort of sensation in the esophagus or abdomen that then triggers a habitual abdominal wall contraction that then causes material from the stomach to come up into the esophagus. And this process of regurgitation basically temporarily resolves this premonitory urge for basically providing kind of a positive feedback onto this loop. And patients can then re-chew and re-swallow or spit out the food. Now, if you focus your attention to the right side of the slide, you will see that there are also secondary psychological mechanisms that contribute to this process. So patients can have learned associations between the abdominal wall contractions and certain cues, like, for example, certain food triggers or like specific activities that are not necessarily always related to food. Some patients also have very low tolerance for these premonitory urges, so it further pushes them to develop this behavior. Some people also have body image issues that basically helps to drive this behavior. So for example, some patients will actually spit up their regurgitated food in an attempt to lose weight. And, some people actually do find the taste of the regurgitant pleasant, and they find this rumination process actually soothing. So again, further reinforces this behavior. So now if you look on the left side of the slide, you will see that there are also secondary pathophysiologic mechanisms that contribute to this behavior. So some patients will have belching that precedes or happens around this same time as the rumination event, and for some people, the rumination event is preceded by acid reflux as well. So rumination syndrome is really characterized by recurrent postprandial and effortless regurgitation, so really no retching. And I think in clinic, it's really important to differentiate whether your patient truly has symptoms of regurgitation or vomiting or reflux. Those are different things to different people, but regurgitation is really no effort, no retching. Vomiting oftentimes is associated with nausea. So rumination syndrome symptoms can oftentimes be confused or, be mistaken for other conditions because a lot of the symptoms can sound similar. So I'm going to go over here just some of the typical symptoms for each of these disorders. There are exceptions to these to these symptoms, but basically rumination syndrome generally happens after every meal or with every meal, usually happens soon after eating within an hour. The regurgitant often lacks a sour, bitter, or acidic taste and tastes similar to recently ingested food. Because it's a behavioral issue, again, you usually don't have symptoms when sleeping, and it can cause weight loss in up to 40% of patients. And usually, rumination syndrome does not cause electrolyte disturbances, dental erosions, malnutrition, or esophagitis. GERD, on the other hand, can happen when someone's sleeping. They usually have more heartburn that's reported, and generally it does not cause weight loss. Gastroparesis is oftentimes associated with nausea or retching. Happens usually the vomiting or things coming up usually happens later after eating by more than an hour, and the food that comes up is usually no longer recognizable when regurgitated, and it doesn't necessarily happen with every meal. And the other thing, the symptoms of eating disorder is very variable, so I'm not going to go into the details here, but I do think it's a really important diagnosis to keep on your differential when you see someone with prominent regurgitation or vomiting. Rumination syndrome is classified by both the Rome-4 criteria and DSM-5. I'm going to just focus on the Rome-4 since I think we're all more familiar with that. In order to meet the criteria, you really have to have persistent or recurrent regurgitation of recently ingested food into the mouth with subsequent spitting or remastication and swallowing. And regurgitation is not preceded by retching. These criteria have to be fulfilled for at least 3 months, with symptom onset at least 6 months before diagnosis. And these are some of the other characteristics that further support the diagnosis. So effortless regurgitation events are usually not preceded by nausea. Regurgitant contains recognizable food, which may have a pleasant taste, and the process tends to cease when the regurgitated material becomes acidic. And really, we can diagnose rumination syndrome based on clinical history alone, but we can also diagnose it on esophageal high-resolution impedance manometry. So as you can see in this manometry photo here, this is a rumination event, and it starts out with increased gastric pressure. So the patient is doing a Valsalva maneuver. This then generates this retrograde pressure wave, so that liquid bolus coming up into the esophagus, and that's followed soon after by a swallow. And you can see on this impedance tracing here, basically the liquid bolus coming up and then being swallowed back down into the stomach. And in one study, postprandial gastric pressurizations of more than 30 millimeters of mercury was actually 100% specific for rumination syndrome. There are actually 3 subtypes for rumination syndrome. So this is picture of the manometry, and the 4 white lines that you see are the impedance tracings that overlie it. So there's primary rumination, which is a rumination event that's not preceded by any leading event. There's secondary rumination, which is where the rumination event is preceded by a reflux event. So as you can see in this manometry, the lower esophageal sphincter relaxes, the impedance drops, some liquid comes up, and this is followed by the rumination event. And then the third type is supragastric rumination. So that's where the rumination event is preceded by a supragastric belch. And as you can see here, you see that inflow of air on the manometry correlating with the rise in impedance shortly before the rumination event. In terms of treatment for rumination syndrome, patient education and reassurance is really important. And in clinic, I often find that just even showing them the manometry picture and going over with them what is happening physiologically is very helpful for them. First-line therapy is really diaphragmatic breathing, which our next speaker will talk to you more about. But you can do biofeedback therapy with high-resolution manometry or electromyography. Other non-diaphragmatic breathing-related treatment include cognitive behavioral therapy. You want to make sure to treat any comorbid psychological disorder like anxiety. Baclofen has also been looked at for rumination, and as we know, it suppresses the transient lower esophageal sphincter relaxation. So they have done randomized control crossover study. This is a small study with 20 patients, and it did show significant improvement in rumination events, increase in the lower esophageal sphincter pressure, and a decrease in the number of transient lower esophageal sphincter relaxation. Not really reported in adults, but the 2 case reports in the pediatric patient population showed that having them chew gum soon after they eat can also reduce rumination events. Other things have been looked at for treatment of rumination syndrome, but hasn't been as effective for treating it. So neuromodulators we often use to treat comorbid disorders of gut-brain interaction like IBS, but it hasn't really been shown to be effective for treatment of rumination syndrome alone. Other things like acid-suppressing medications, prokinetics, antiemetics have also unfortunately not been shown to be effective in retrospective studies. And surgery such as fundoplication, there's really no data to support long-term effect, so really not currently recommended. So in summary, rumination syndrome can be diagnosed with clinical history alone or esophageal manometry. You could it's important to clarify with your patients what their true symptoms are, whether it's regurgitation or vomiting or reflux. First-line treatment is really patient education and diaphragmatic breathing. And if that's not effective, you can do diaphragmatic breathing with biofeedback if available, or cognitive behavioral therapy, or using Baclofen. And it's also important to treat any comorbid psychological disorder. Thank you.
Thanks, Lisa. That's really good. I was just thinking while you were talking, and when we do manometries on these folks to identify these unusual kind of belching things or rumination, we actually don't do what most labs do. And what we do is we have the patient, in all these cases, we do the manometry, and then we have the patient just relax. Or we actually feed them something and then leave them in the room by themselves for a while. And we tell them to push the button on the recording device when they have the symptom. It's really important to do that kind of thing when looking for these unusual belching phenomenon. Okay, so now our next speaker is Suzanne Smith. She is an integrative health nurse who works in the motility group and the functional group. She's going to talk to us about her approach to treatment of rumination syndrome. Probably a little editorial aside, this is probably the best way to manage these patients.
Good morning, everybody. So I'm going to talk about why diaphragmatic breathing is indicated for rumination syndrome, talk about evidence to support its efficacy, touch on psychosocial factors, and then give some pointers to how to teach your patients diaphragmatic breathing. So here's a picture of the diaphragm. And as you know, there's the esophageal hiatus right here, which is made up of the right crust of the diaphragm. And this right crust acts as a physiological barrier, so it keeps food from coming up from the stomach into the esophagus. So as Dr. Lin mentioned, it's not completely understood, rumination, but what we do know is there's this unintentional contraction of the abdominal muscles, which leads to a cascade of events. So increased intra-abdominal pressure, increased intragastric pressure, the lower esophageal sphincter relaxes, and there's voluntary relaxation of that right crust that I showed you. And this creates a pressure gradient, which allows food to move up into the esophagus. But in contrast to that, when you look at the physiology of diaphragmatic breathing, it does the opposite. So when we breathe in diaphragmatically, when we inhale, this increases the activity. The diaphragm moves down, it contracts and flattens. This relaxes the abdominal muscles. This reduces postprandial gastric pressure and increases the GE junction pressure, which does not allow this gradient to occur. And we can see this on manometry here. So you already saw the manometry of rumination. This here is that Valsalva maneuver, and where the arrows are, and where the stars are, this is the gradient where the bolus moves effortlessly up. This is diaphragmatic breathing under manometry. And I think this is pretty amazing. See how this just keeps the contents of the bolus where it needs to be in the stomach. So I want to talk about some evidence for diaphragmatic breathing for rumination syndrome. So there's been various studies that have been done, some without biofeedback and some with that biofeedback. So these two were done without. The first study, 15 adolescents and adults, it was an open label study, and as you can see, they had a good responder rate. 66% of symptoms were resolved. 20% had a 50% reduction. The second study, this is the largest retrospective study done, 54 patients. Now, the age of these patients were from 5 to 20 years old, so they were a much younger population. but they still had a pretty good responder rate. 30% had symptom resolution, 56% had symptom improvement, and 13% had no improvement. So in this study, they also did other behavioral treatments such as relaxation training, progressive muscle relaxation, but I also want to point out that 16% of these people had psychological comorbidities. So then there's diaphragmatic breathing with biofeedback. So in this first study, what they did is they used EMG to teach the patients diaphragmatic breathing in 3 sessions. And then they had them go home and practice for 5 minutes before and after meals. They had a 70% reduction in their symptoms after only 20 days. And this improvement was sustained at 6 months. 4 patients did not improve, and to note, they had psychological comorbidities. And then this same group decided to do a randomized placebo-controlled trial with the same treatment, but they used oral simethicone after each meal as the control. And the results, as you can see, 74% reduction compared with only 1% with the simethicone. They had them continue to practice for 6 months, and they had further reduction in their symptoms. So at a patient visit, I think it's really important to assess the patient's understanding of the diagnosis. Many of these patients have waited years to get a diagnosis. They've been to see many doctors and had many tests. So I want to make sure that we are reassuring them that we know what they have and that we can work together to treat it. I also want to know what are their presentation of symptoms so they can apply the diaphragmatic breathing most effectively. And then also assess psychosocial factors. So educating them, discussing the reason for diaphragmatic breathing, talking about the physiology, showing them manometry readings, and demonstrating the breathing and practicing, making sure they really understand how to do it correctly and offering guidance. So I want to touch on the psychosocial factors briefly because there's a significant impact on these patients' quality of life and daily functioning. So the things that are important to assess are what is the impact on their individual quality of life? What life stressors are happening? Because oftentimes these episodes start with a stressor. So what are they having things that are stressing them that are driving this mechanism? Any presence of avoidance behaviors? Do they not like to eat with friends or eat out? What are their worries and fears? And what are their expectations of treatment? And this is important to assess because you want to evaluate should we get a GI health psychologist involved in their care. So teaching diaphragmatic breathing. I always have people lie down on the exam table first because the body relaxes and most people actually start breathing from their diaphragm. That way I can have them know that the body already knows how to do this and then we enhance it after that. Once the proper technique is demonstrated, it's important to have them sit up. They really need to learn this sitting up because this is when their symptoms occur 10 to 30 minutes after ingesting meals. So tomorrow I'm actually going to be demonstrating diaphragmatic breathing. We're all going to practice together, so I'm just briefly going to go over the steps now. So what you want to do is you want to have them place one hand on the chest and one hand below the ribs. And this is kind of just to cue them. Then you have them take their normal breath and you have them understand, as Lisa was talking about self-awareness, how are they breathing normally? And then what you do is you teach them diaphragmatic breathing. So you have them breathe in through the mouth. And what they're doing is keeping the chest motionless and only letting the abdominal muscles work. So as they breathe in, the diaphragm comes down and this abdominal muscles relax, and then they breathe out through the mouth. And you just have them continue to practice this until they demonstrate proper technique. Diaphragmatic breathing, as you saw on the manometry, is incompatible with this abdominal wall contraction, which is what's driving their symptoms. So when do you have them practice breathing for rumination? Well, it depends on their sensory feeling. Each patient is different. If they don't know when they're having their symptoms or they're not that clear about it, have them keep a journal. This also builds that self-awareness. The goal is to retrain them with the breathing. So we want this to start coming up unconsciously after they eat instead of having their abdominal muscles contract. So it's best to have them practice before, during, and after meals for 5 minutes, and after each episode of regurgitation. But what's really important is to have them get this down, so practice it when they're not eating. So doing it regularly on a daily basis. So for severe symptoms, we want them to practice for 5 minutes, 3 to 5 times throughout each meal with 10 minutes in between. So just some things to consider when you're teaching people breathing. It may be awkward for some patients, especially patients who have anxiety. So you want to think about, should I be referring them to someone who can spend more time with them, really have them get this technique down. Body image issues can come up when you're breathing in and your abdominal muscles are relaxing and coming out. This makes some people feel very uncomfortable. So you need to address this in the office when you're teaching them. Have them wear loose clothing when they're practicing. And if refractory, consider other comorbidities and treat any secondary psychological comorbidities is really important. And interdisciplinary team is important to the care of a patient with rumination. So thank you.
So, very good. Okay, next case. MT is a 16-year-old complaining of dysphagia. He had episodic vomiting at 6 months of age after intake of any solid foods. This started after he was taking formula. Triggers for his vomiting were things like fatty foods, ice cream, cheese, and milk. He was treated, as is everybody who has this kind of symptom, with famotidine, and it did not improve. He had a 24-hour pH study done. The pH was below 4, 6.3% of the time, and normal is less than 5.6% of the time. So he had a little bit of reflux, but not a lot. His gastric emptying study, however, was quite abnormal. He should have had greater than 50% emptying at 90 minutes. He had an upper GI that was normal with a small amount of fluid in the stomach. At age 3.5, he had a Nissen fundoplication. He had, interestingly, he had large Ladd's bands coursing between the duodenum and the liver. These were divided, as any surgeon would do in this situation. It did not improve his symptoms in any way. He continued gagging and retching with eating. His current symptoms, when we saw him, he was taking an hour to eat every meal at the least. He had epigastric discomfort, like something being stuck when he put food, actually when he just put food into his mouth, he would have this symptom. He then started to chew, and he would chew very slowly, and as he was chewing and swallowing, he would chew more and more slowly. He actually had a fear of eating and was worried about swallowing. He would not go out in public to eat, and he was avoiding his friends. His mother reported that earlier in life he was at a camp and he got a tic, and the tic was turning his head over and over. This was treated successfully with CBT. So here is his endoscopy. And what you see here is a normal esophagus and a fundoplication that looks intact. It does not look too tight. Does everybody agree with that? Okay. Biopsies did not reveal eosinophilic esophagitis. He had a barium swallow, basically normal. And he actually swallowed some solid material, and it passed through without any difficulty. Here's his esophageal manometry. And you can see that he has adequate peristalsis. The lower esophageal sphincter opens appropriately, so this is not a motility abnormality that we could define. And in fact, we couldn't find any physiological reason for this young guy to have dysphagia. So, Christina. Christina Gentile is she is our GI psychologist. She has been a great addition to the division, has helped a lot of people in situations like this where we can't find a pathophysiological problem, and they have some kind of funny stories. So she's going to talk to you about how this young man was taken care of by her.
Okay, so when the patient presented to GI health psychology, he had a lot of significant anxiety and worry about his esophageal sensations. As Dr. Conklin mentioned, he had concerns about his ability to swallow, and he had significant fear of choking. And he tended to have a lot of anticipatory anxiety, especially at dinner. He described dinner as being his most problematic meal when he tended to have the most bothersome symptoms. And what we started to see was that there was this pattern with him managing his anxiety through safety and avoidance behaviors. And what this included were things that Dr. Conklin described: excessive chewing, prolonged eating at meals, skipping meals, and avoiding certain food items. And also associated with his distress was that he had a lot of different psychosocial stressors related to academics and his athletic performance. And what we saw was that these stressors tended to build throughout the day, and he didn't really have any good coping skills or stress management skills in place to help him regulate those. And I'll talk about that more in a moment. As a pretreatment measure, he completed the Esophageal Hypervigilance and Anxiety Scale. This is a measure that was developed by Taft and colleagues at Northwestern University in Chicago. And you can see his scores listed above, and it ranges on a scale from 0 to 60, with higher scores more indicative of the construct that is being measured. His symptom anxiety subscale looks at the cognitive mechanisms associated with symptom anxiety, so this idea of catastrophizing, where patients are likely to then awfulize their symptoms, saying, this is horrible, and feeling very helpless with their ability to control or manage the symptoms. And the hypervigilance, looking at this behavioral pattern of selectively attending to those sensations and monitoring and detecting any variance in change. And since dinner was his most problematic, we just looked at in terms of over the last 7 days, how often were you experiencing these dysphagia episodes, and he endorsed 6 out of the 7. So I wanted to present then a biopsychosocial formulation to help us understand how GI health psychology can be used to help a patient like this. And by the time he approached dinner, there were 2 things at play that happened. As I mentioned, he had significant stress related to school and academics, and this stress basically built up throughout the day. And by the time he got to dinner, he was very aroused. He had a lot of autonomic activity. At the same time, there was a lot of anticipatory anxiety about dinner. He approached dinner with dread and was making these faulty predictions about him having some sort of adverse outcome. And this ultimately resulted in a few things: him becoming very hypervigilant to any changes that he was experiencing. At the moment he started to notice any changes in his esophagus, he started to have these faulty threat appraisals where he started to have more catastrophic thinking. He would endorse thoughts about, oh my gosh, this is going to be another issue. I'm not going to finish eating my food. I don't feel normal. And he would have this perceived loss of control. And this ultimately then set off an interacting relationship between his thoughts, what he was saying to himself, his emotions, and this fear-based physiological response where we see increased autonomic arousal. And as we all know, that can also worsen esophageal and gut sensations. And then these maintaining factors with behavioral avoidance, so either skipping foods or using these safety behaviors to manage the distress with the meal, as well as this catastrophic misinterpretation of these signals, or rather sensations. So I wanted just to provide a general overview of treatment. We did two things. We did esophageal hypnosis, which is an evidence-based brain-gut psychological treatment. We emphasize that in the beginning portion, which you can see is shaded in blue. The gray boxes indicate areas that were more of a less focus of treatment. The later half of treatment, we decided to include then GI-focused cognitive behavioral therapy to tackle some of this fear and anxiety and avoidance around food. And I'm going to go into more details about these treatment modalities tomorrow, but as a general overview, with esophageal hypnosis, it's a form of medical hypnosis. So usually when I present this to patients, I have to correct some of these myths and let them know this is nothing like, what you might see in Las Vegas or on TV. It's a form of helping you achieve a very, very deep and focused state of relaxation. And in doing so, we use different ways of helping the patient achieve this deep state of relaxation. We're using things such as diaphragmatic breathing, as Suzanne has discussed, progressive muscle relaxation, and we're also pulling in imagery. And the imagery is connected to these esophageal sensations. And so we're using calming and soothing imagery to help the patient correct any ways in which he's misperceiving these sensations. So when we pull in the hypnotic suggestions, which are verbal repetitions, we're helping his brain begin to start down-regulating pain processing and unpleasant sensations. So we're trying to alter the perceptual experience. And with our hypnotic suggestions, we want them to be uniquely tailored to the patient. So for him, since he was endorsing significant fear with swallowing, it was important then to hone in on this. And with these suggestions, like as I mentioned, we're pulling in imagery. So for example, more and more you begin to feel confident in your esophagus's ability to function in a steady flow, natural rhythm, imagining fluid flowing down like a gently flowing stream. So we want the patient to begin to feel this in their body, see it in their mind, with the imagery, and we're using language to help develop this positive association to their sensations. So we did this about 4 times. He came in to session. We would do the hypnosis, and he received a recording to practice at home, and he was encouraged to practice most days per week, but he's a teenage boy, so we had to encourage him and reinforce the importance. But it was important because he saw when he wasn't practicing, he started to have more of these unpleasant sensations return. So once he developed mastery with this, we decided to move on to more of a GI cognitive behavioral approach. And with this aspect of treatment, we did a few things. We did exposure-based treatment, and we included cognitive therapies. With exposure, we worked together to identify his most feared foods and food items that he's been avoiding for a significant period of time. And he would bring these into clinic. So my office smelled very delicious, actually. We had French toast, burgers, pizza, and he would practice eating these as he was using different skills, behavioral and cognitive skills, to manage that distress. And as he learned that he could eat these food items with not having this adverse prediction, this adverse outcome, he started to gain a sense of control. And what this did was it served to help disconfirm that faulty belief he had about his symptoms and this fear that he might choke and there's going to be some sort of horrific consequence. And he would go home. He would also practice these exposures at home. And what we saw was then between session habituation. And what this essentially means was that between each visit, that fear and anxiety began to decline. With the cognitive interventions, we were tackling how the faulty appraisals that he was saying to himself, so how he was approaching his sensations, and also how he was approaching stress, because as I mentioned earlier, he had a lot of stress that would build up build up throughout the day, and by the time he got to dinner, it would basically just boil over. So he learned how to decatastrophize, which means instead of looking at the worst case scenario, can we help you find some sort of balance in terms of finding a more realistic outcome? And should there be a problem, how can we help you use some flexible problem-solving skills to manage and navigate that situation? So we essentially wanted to help promote some self-efficacy with this patient. With mindfulness of thoughts, we wanted him to also begin to recognize when he was starting to make these faulty threats or threat appraisals about his sensations and symptoms, and take a non-judgmental stance, allowing them to come and go, where he's not buying into them and becoming hooked and basically thrown off his course of life, so that he could re-engage with things that bring him joy and what he values. And he would practice those skills as well at home. So at the conclusion of treatment, he recompleted the esophageal measure, and what we saw then was a general decrease in scores across the board. So as you can see, his total score went down, as did the subscale for anxiety and hypervigilance. Although he still presented with some symptom-related anxiety, it was not as bothersome. He was better able to manage, because what he learned that was a very, very important point was that he needed to practice skills throughout the day, whether it was how he was talking to himself, how he was approaching stress related to school, or the stress related to these bothersome sensations, and use these skills to help lower arousal, so that by the time he got to dinner, he was able to eat more foods that he enjoyed. And I want to just bring our attention down then to that last item in terms of the frequency of dysphagia episodes. When he came in, he reported he experienced these 6 times over the last 7 days at dinner. And at the end of treatment, he reported 0. And he also was self-monitoring this, and Mom also agreed that she hasn't seen this even occurring for the last 2 weeks. So with this, he was able to reintroduce more foods. He was eating French toast. He was actually eating probably what we would see of an average teenage boy. And he was really excited because he didn't feel as hungry anymore. So the big take-home point then for him was he needs to practice, and he needs to also develop self-awareness of when his anxiety is starting to intensify and where his key vulnerabilities are with his stressors. Thank you.
Thanks a lot. She has really changed the practice in our GI division. There's no question about that. So, DO, 52-year-old woman with chest pain. She had solid food dysphagia starting in her 20s, and she had her first food impaction in her 30s. Her dysphagia was felt in the suprasternal notch, so right here, worse with bread, meat, and potatoes. She did not have heartburn, nausea, vomiting, or melena. So with that history, fellows, what would you think? EoE. Okay, good thought. So she was in Libya with her husband. She was eating a chopped salad, and she said she felt an explosion in her chest. Odd symptom, right? It was followed by severe chest pain. She went into the hospital there. She was told that it was her gallbladder. She had cholecystitis. Fortunately, her husband, who was an oil guy, was a bright guy, and he said, I don't think that sounds right. She was flown to Malta, where a diagnosis of esophageal perforation was made. She was treated with antibiotics, TPN, and a chest tube. No surgery. Pretty amazing. After 6 weeks, she returned to the U.S. and continued to have dysphagia. Now, I'd say she's lucky, right? So this was her manometry as part of our studies to evaluate her dysphagia. Like one of our other patients, the esophageal gastric junction is not opening, so the lower esophageal sphincter is not relaxing. And there's panesophageal pressurization. That is, there's a simultaneous pressure wave that goes up and down the entire esophagus, and it's associated with swallowing. So this looks like achalasia. And it looks like type 2 achalasia, right, with panesophageal pressurization. So she actually was referred to me by a thoracic surgeon. I should have said that sooner. And when he saw this, he said, I need to do a Heller myotomy. Can you see this? Is that pretty clear? So I also got a barium swallow on her, and this is the barium swallow. You see anything funny about this? So I saw these rings in the esophagus, and I said to him, no, don't operate on her just yet. Let me scope her first. And so I did, and this is what we saw. So what's the diagnosis? Just endoscopically. EoE. Those are the biopsies, and sure enough, she had lots and lots of eosinophils. So the diagnosis was eosinophilic esophagitis, showing you that eosinophilic esophagitis can present manometrically in a number of ways, including looking like achalasia. So, Kevin, I promised you not to torture you on the stage, but I'm going to ask you, what are the medical therapies that we can use now in the treatment of eosinophilic esophagitis?
So historically, or recent history, was that the first-line therapy is double-dose PPI, as is mentioned in the first line there. Although the most recent guidelines coming from Europe actually say that that doesn't have to be the case. So really the main medical options are PPI and topical steroids, whether it's using an inhaler like fluticasone and swallowing it instead, or taking budesonide, the respules that are used for nebulizer, and mixing them with, usually it's been sucralose, although other media can be used to make a viscous solution that can have a better coating effect. There's evidence to suggest that either one can be used first, although in this case, given how high up it looked like there was those rings and given the severity of it, I probably would have started with steroids first.
Fair enough. So as you can see, she refused steroids. So we're in this situation where the proton pump inhibitors did not help, and she's not going to take steroids for whatever reason. The question is there anything else we can do? Nancee? This is Nancee Jaffe. She's one of our GI dietitians, another person who's made a big difference in the practice. Is there anything else we can do for this guy?
There is. Thank you. Thank you, Jeff. So I have the honor to speak on some of the current research that we're seeing with elimination diets in eosinophilic esophagitis. And I'm also really excited to talk about the new model that we've created at UCLA to work with this group of patients and how we're going about utilizing the diet research that we've had. So before we go into the research on EoE, I thought we should first define what an elimination diet is. So historically speaking, an elimination diet is a procedure used to identify foods that we think are causing an adverse effect in a patient. And what we do is we remove all of these suspected foods, and then we exclude them for a while, and then we bring them back. And I think it's really important that we add a couple of elements to that historic definition. We need to be very specific about the foods that we're choosing. So this isn't just what food, but what food components, what food composition, what elements are we trying to get to? And you'll understand more of what I mean by that as I move through my talk. We also want to make sure that this is done for a set period of time. So elimination diets are not meant to be long-term solutions. They're not meant to be the diet for the rest of the patient's life. So there are actually 3 very specific phases that we want to make sure we hit when we do an elimination-style diet with a patient. We want to start with what's called the elimination phase, which is when we remove all of those specific food and food components that we think might be triggering for a patient. After that, we want to bring them through what's either called the reintroduction or the challenge phase, where we're actually challenging the assumption. Did those foods actually help? And if they did, which ones of the specific foods that we removed actually were causing the problem? And then from there, we can move into what's called a maintenance phase. And this is where we take the data that we've collected from the other 2 phases, and we actually create a long-term intervention that hopefully does not decrease quality of life in our patients. Especially in the case of a dietitian, we're talking about food, and food is very pleasurable, and it's very social. And we want to make sure that we take those elements into consideration when we're working with this patient population. So how did we come up with the elimination diet? So basically, this all started with Dr. Albert Rowe, who was the chief of allergy at the University of California Medical Center in San Francisco. And he actually wrote a paper that you can see there in the 1940s, where he first started talking about the need of these elimination diets to work with allergic patients. We then had another study that came out by an Australian group in the 1970s, where they actually started to put into detail the different steps we should be using for an exclusion diet. And this actually helped to set up some of the double-blind placebo-controlled trials that we use in allergy today. And nowadays, elimination diets are used by all sorts of different types of practitioners, and mainly they're used to look for different types of food allergies and possibly food sensitivities. And the most important part of that type of elimination diet is that we're removing what's called the 6 leading allergens. So that includes dairy, soy, tree nuts, which includes peanuts, fish, which includes seafood, eggs, and wheat. So you may hear it called the top 8 allergens. Just so you know, the top 8 and the 6 are the exact same thing. It's whether we pull out peanuts from tree nuts and seafood from fish, identical. In this case, we're going to be talking about them as the 6 foods. So where did the research start with eosinophilic esophagitis? So the first study that was really done with this cohort of patients was done in the late 1990s by the pediatric group at Johns Hopkins Medical Center. And what they did is they took patients who were refractory to other types of medical intervention, and they put them on a hypoallergenic elemental formula to remove all of the proteins from the diet, since we know that proteins are usually the most allergic part of the specific foods that we're worried about. These patients were only allowed to have clear liquids, and they were allowed on occasion to have corn and apples. Again, this was a pediatric population, so that was for those who could actually chew. And what they found is that when patients were put on this elemental diet for 6 weeks, just to point out, this was a small study. There were only 10 patients on it. But while they were going through the elimination part where they were on the formula, 8 out of the 10 patients had significant reduction in their symptoms. So they were feeling almost completely better. 2 of them actually had full remission of their symptoms. And when they went in and they actually did an endoscopy, they found that the eosinophil count was reduced to the point of remission in over half of the subjects. And that the median rate for improvement was actually about 3 weeks, and that in order to see maximum, it was about 6 weeks. So this is how we started to learn about timeframes and what timeframes we should be thinking about when we're looking at diet intervention for this patient population. But of course, putting patients on an elemental diet for the rest of their life is not a good option, right? We don't want to do this to our patients. And especially adults are not going to be wanting to follow suit with that. So other groups started to look at the elimination diet. And so this was one of the first studies in 2006 to look at the 6-food elimination diet. And what was great is they compared it to that exact same formula that the other group had used. So they found this hypoallergenic formula. They gave the elemental exclusion diet to half of the cohort. In this case, it was 25 children. And then the other 35 children were actually placed on the 6-food elimination diet for 6 weeks. And what they found is that about 74% of the children who were placed on the 6-food elimination diet had clinical remission of their eosinophilic esophagitis under endoscopy, and that was compared to 88% in the elemental group. So yes, the elemental group won out, but not by that big a margin, and the 6-food elimination diet is a much better tolerated protocol. The other thing that came out of this research is that we started to see which foods were the most common problems in this patient population. And what we saw was that milk overwhelmingly was the biggest issue, followed by wheat, eggs, and soy. So another group went, well, what if we actually start to look at adults and we start to figure out if maybe the 4-food elimination diet would be enough? Do we really have to remove all 6 food triggers from the diet? So what this group did in Spain was they had 6-week 4-food elimination diet. It was a multi-center study. Because it was in Spain, they decided to remove all mammalian milk, not just cow's milk, all gluten grains, not just wheat, and then legumes as well as soy and eggs. And what they found is in their 52 adults that participated in the study, 54% of them achieved both symptomatic and histological remission of their symptoms. And what was great is they then took the patients who did not respond to the 4-food elimination diet, and they gave them an option of going on to the 6-food elimination diet. And with that option, they were then able to rescue 31% of those non-responders. So we ended up with quite a significant number of the patients who had clinical and histological remission. And again, we're seeing which foods tend to be the most problematic. Even in the 6-food elimination diet group, milk, eggs, wheat, and soy tends to be the big triggers. And again, milk overwhelmingly is the largest problem in this patient population. So I wanted to show you one more study. There's actually quite a few studies on EoE. I just wanted to show you the ones that we really focused on to help come up with our protocol at UCLA. So that same group that we just saw in Spain who did that 4-food elimination diet, they then asked the question, well, do you need 4-food? Could you do 2-food? So do we need a 2-food, a 4-food, or a 6-food elimination diet? What will give us the best results? And in this case, they went big. They got 14 different centers, 6-week protocol. Everyone was started on the 2-food elimination diet. If they failed the 2-food, they were then increased to the 4-food. If they failed the 4-food, they were increased to the 6-food. And you can see the results that they got. So on the 2-food elimination diet, they were able to achieve remission in 43% of the patients. And what they found is, yes, they had a teenage cohort, so that's what they mean by the pediatric population. It was actually teenagers. But they found there was no difference between the pediatric population and the adult population. They responded identical to this intervention. And again, we found that dairy and wheat, biggest triggers. For those patients who did not do well on the 2-food and were stepped up to the 4-food and the 6-food, we ended up with 60% and 79% remission, both of symptoms and of their histology. So this is pretty impressive results. One thing that we learned from this study is that if a patient is put on a 2-food or a 4-food strategy before they are moved to the 6-food, we might be able to save up to 20 to 30% of the endoscopic procedures necessary. And that might be a question you're asking is, how many endoscopies does it take to actually figure this out? And we're about to show you what it takes. So what we've decided to do at UCLA is to start with a 4-food elimination diet, and then we can always step up to the 6-food elimination diet. If a patient has a very strong allergic history, we may start them at a 6-food elimination diet, or if they have already a good sense that milk and wheat are their big triggers, we may even choose to step it down and start it at 2-food. But we always go for a 6-week intervention during that first elimination phase, which is followed up by endoscopy to make sure that we achieve less than 15 eosinophils per high-powered field, clinical remission, and then we can start the reintroduction phase. If a patient does not achieve that outcome, then of course they're going to be stepped up to the next intervention in diet, or of course they can consider other treatment options. So I don't want to go too in depth in this, but I wanted you to have this information in your slides so that you could be thinking about the types of foods that are necessary to remove for the 4-food elimination diet. And this is actually where a team approach is really important, and having your dietitian available. We're lucky at UCLA to have 3 GI dietitians now who are able to work with our patient population so that we make sure we're rooting out any problem foods that might otherwise not be noticed. So for instance, not everyone thinks that there's they need to look at their salami to see if it actually has milk protein in it, which, by the way, a lot of them do. So this is something that the dietitian can do with the patients. We also know things like you don't have to worry about soy lecithin or soybean oil. They don't contain the allergenic protein, so patients don't have to freak out every time they see soy lecithin on a packaged food that would otherwise be safe. Also, we don't require patients to go gluten-free, but we may recommend that they use gluten-free oats during the elimination phase because oats can be very highly cross-contaminated, and so there could be enough wheat in there to potentially cause the problem that we're trying to assess for. Of course, if we put the patient on a 6-food elimination diet, we include or exclude everything that was on the previous slide, and then of course we have to take out the nuts and the fish as well. So how do we create success with our patient population? We need to make sure that we're giving them very clear, identifiable foods that they need to remove and foods that they need to keep in the diet. We want to offer them grocery lists with lots of brands. We need to make sure that we find the foods that are most important to them and that we find them good, pleasurable alternatives because they're going to be on this diet for a while and we do not want to decrease their quality of life any more than is necessary. Hopefully we can really find a lot of good options for them, and there are so many good alternative products out there nowadays. We do a lot of meal planning and meal strategizing, and then we also help to create realistic, attainable goals and expectations so that they have an understanding of how long it takes for symptoms to start to be reduced, what we can expect with percentage-wise from the endoscopies, and how long the process potentially could be. So the next part is that we want to go over a challenge phase. So this is probably the most complicated part of the intervention. So if a patient successfully makes it through the elimination phase, they're having both clinical and histological remission of their symptoms, what we do is we bring 2 foods back at a time for each of 2 weeks for the least reactive foods. And then for the most reactive foods, we do them 1 at a time for each of 2 weeks. And if there are symptoms, which usually can start occurring within about 5 days of adding the food back in, we may actually need to speed up the timeline, or we may need to have them pull back on eating that food until closer to the next scheduled endoscopy in order to make sure that we're not basically torturing our patient, right? We don't want them to be suffering needlessly. We just want to find the answers that we're looking for. So when I said the least reactive foods, what I meant is if you're on a 4-food elimination diet, we're starting with soy and eggs. And if you're on a 6-food, you start with fish and nuts. And we always want to make sure that we're using a very pure form of the food. So if a patient is going to do nuts, we don't want them to do something that also contains wheat or contains eggs. It needs to be just pure nut butter or just a handful of nuts. And there really aren't great guidelines for how many of these foods, what the dosing is that we need to use. So what we're doing is we're starting at about 20 nuts or 1 tablespoon of a nut butter, 1 egg per day, 1 glass of soy milk. So we're starting with just nice round numbers, a good amount, enough that it really should cause a reaction, if they're willing to stay with that dose for those 2 weeks. The most reactive foods, as we mentioned, are milk and wheat. So we want to make sure that we choose very, very pure forms of these, and wheat can be a hard one because wheat is often mixed with some of our other allergens. So choosing just a wheat pasta or like a saltine cracker might be your best way to go. I also wanted to point out, so you may have noticed in some of the studies that they removed all mammalian milk, which included goat and sheep milk, and they removed all gluten-containing grains. There have been several studies in the US, including one by Goncalves and his group in 2012, and another one in 2017, where they actually looked at a US population, and they found that it was unnecessary to remove all gluten and all mammalian milk in our population. And it's in part because in Spain, they eat a lot of legumes, and they drink a lot of other types of mammal milk. We don't really have that issue here in the US, and so we can really focus on cows, dairy products, and we can really focus on just wheat as our source. So I hope you can see this okay. It's a really complex matrix that our esophageal group has come up with, and it was based on not only the research that you saw, but we also did a deep dive into what other academic universities are doing across the country, and this is what we came up with. So basically, just to orient you, the yellow that you're looking at are endoscopies. The blue is when a food is being reintroduced, and red is when there is reaction. So a basic example of how this algorithm works is a patient will be put on, this is the 4-food elimination diet for 6 weeks. They would then have the endoscopy hopefully showing remission. Then they would add soy in for 2 weeks. Hopefully there's no symptoms, and they're able to then bring in eggs for 2 weeks. After those 2 introductions, they then go in for their next endoscopy. If they are continuing to be in remission, they get to move on to the next set of food challenges. If they unfortunately had recurrence of their symptoms, it means we've added in one of their trigger foods. So again, we pull out the most likely culprit, and we have them then do kind of like a washout challenge for 6 weeks. So as you can imagine, this can take some time. And it's really important that we're doing an individualized approach for our patients, because we have to consider factors such as medical indication, risk-benefit discussions, insurance coverages, and patient preferences. But we've got a really good team, as you can see, including an amazing nurse practitioner, Sonia, who's in the room, who really helps us to coordinate care and make sure that we're doing the best we can for our patients. And then you can see the 6 food gets even more complicated. So we all have laminated copies of this in our offices that we can actually use with our patients to help them understand the process and how we're going to go through getting them through the process. So the last part is the maintenance phase, which of course is when we've finally gone through all of these endoscopies. We've hopefully figured out the 1 or 2 food triggers that are the offending agent for them. And we're now able to bring back everything that was not a problem and only focus in on those trigger foods. From there, we want to make sure we create adequacy and balance in the diet. So again, this is where having a dietitian as part of your team is really important. We want to make sure that if we've removed something that has key nutrients, such as dairy products, we want to make sure we're giving those key nutrients such as possibly calcium, vitamin D, maybe zinc back into the diet in other forms, and that we're alerting the patient to that. We also want to make sure we supplement appropriately if necessary, and then of course it's important that the patient continue to follow up with their physician. As a reminder, diet is an option with your patients. Considering whether the 2, 4, or 6 food elimination diet is appropriate for your facility and your patient population is really important, and making sure that you've got the staff that you need in order to accommodate these patients. This is a complicated protocol, but we've done it, how many times? About 4 times, I think, together, and we've had some really good success rates, and the patients have really actually been grateful to have options that they feel like they have some say and some control over. And when you actually hit on what those core triggers are and they get to move on with life and not have to go through this process anymore, you're actually giving them a lot of self-confidence, and you're giving them a lot of their life back. So thank you.
Thank you, Nancee. So, Kevin, I'm going to pick on you again. So during this protocol, this thing that we do, how do you assess success of the therapy?
Well, ideally, it would be great if we could just assess based on symptoms. The problem is that people, and I've seen this just recently, people can say that they feel so much better, yet when we do the endoscopy, there's still quite an amount of esophageal eosinophilia. So you really have, and of course, while we want people to feel well, we want to make sure that we're actually doing them justice and also knowing what exactly are the triggers. So really the endoscopy is the key in taking additional tissue samples to confirm that there is improvement in that inflammation.
Yeah, I think that's a very important point. If there are too many eosinophils in there, they're going to end up with fibrosis and all of the problems associated with that. So it's really important to make sure. Well, okay, another question for you. What's your goal with therapy?
So the goal of therapy is to, well, ideally eliminate dysphagia completely, but really allow patients to have a normal quality of life with regard to the foods that they're eating or can eat, especially if they do endeavor on the food elimination diet. Understanding, though, that because this condition does involve more than just the esophageal mucosa, and there can be some minor motility abnormalities as well, they might still have symptoms, but improving quality of life, so especially for the young folks who avoid eating in social situations with their friends because it just takes them 2 hours to finish the meal that everyone else is finishing in 20 minutes. We really want to improve that aspect of their lives.
So do you have a target for the number of eosinophils?
The research studies say that complete remission is less than 5 eosinophils. If they have less than 15 eosinophils per high power field and symptomatically they're doing better, I'm fine with that.
Okay, that's great. So I'll get back to you in just a sec. We have only 2 questions, so we have time if people want to shout out after these things. So Christina, of course. So our patient with dysphagia, you got him all better. How often do the symptoms come back? What's the rate at which they fail over time?
It depends. It's dependent upon if the patient's continuing to practice those skills at home. So for each patient, there's going to be a degree of variance, especially if there's any psychiatric comorbidity, such as a pre-existing anxiety or a depression. We do see from the research some studies saying at least 6 months to 1 year remission, but again, it's very, very dependent on, is this patient practicing? How adherent are they with their routine practice? Are they fully engaging in it? With this patient, since he had that fear of eating, that was another aspect of treatment that we had to manage. So being able to continue to build those skills so they just become more routine and automatic.
So another question, does the insurance cover the behavioral therapies?
Very good and complicated question as well. So I use the health and behavior CPT codes, and so when I submit my bill, I use the primary medical diagnosis, so for him the functional dysphagia. The other codes are the psychotherapy CPT codes. With those, the psychologist would be diagnosing for example, a major depressive disorder or generalized anxiety disorder. We do see that patients have coverage using the health and behavior codes. However, there's some arguing with insurance panels, having to go back and forth to verify the coverage. But generally speaking, we've seen patients have the coverage with the health behavior codes.
Yeah, that's an important point, actually. All right, so Craig and Kevin. So I'm gonna ask you guys to talk about the role of biologicals in the treatment of EoE. I seem to remember that there was one a few years ago, was anti-IL-5 that worked great as long as it wasn't a controlled trial. And when it was a controlled trial, it didn't work at all. Are there other things on the horizon?
So there are other immunomodulators or antibody-type treatments. However, as Jeff, you mentioned, they're really mainly uncontrolled trials, and they were really designed for other reasons. The problem here is that although IL-5 does seem to be increased in patients with EoE, it just doesn't seem to work well when it's put to the test in a more controlled experimental setting. I personally never had to use it. I've always found something to help the patients that's, let's just say, more in the traditional or standard practice. There's also an anti-IgE antibody, but because this isn't an IgE-mediated disease, it's not surprising that it hasn't been helpful. Everything else is just too infantile right now to say that it has real promise.
Yeah, I think that's right. We don't have the data yet to support the use of these drugs in eosinophilic esophagitis. I think that's pretty much true. Okay, go ahead, Craig.
In terms of the steroids, there is work on an alternative to inhaled fluticasone or budesonide as like a slurry, because you can imagine with the inhaled fluticasone, the majority is going to go into the lungs, and it's really difficult to swallow that. And with the slurry of budesonide, how does that actually stick and attach to the esophagus? So they're looking at oral dissolvable steroid formulations as an alternative to budesonide or fluticasone.
Yeah, I think there's one in Europe that's a capsule that you put in your mouth and it slowly dissolves and gives it time in the esophagus So if you were going to make a slurry, how would you go about doing that?
Basically, you take the budesonide Respule, either it's 1 or 2, 0.5 or 1 milligram. You need to take it twice a day. You need to mix it up with some sort of viscous agent. I've heard honey. Kevin, you mentioned
Sucralose.
Sucralose. Yeah.
Basically, you just want to kind of make a slurry, and then you want the patient to swallow it and almost use it like a lotion on their esophagus. But what's important is once they take this budesonide slurry, they shouldn't eat food or drink any liquids for about 30 minutes, because it's almost like putting lotion on your hands and then washing your hands immediately right after. So if you take this budesonide slurry, no food or drink 30 minutes after taking it.
Just to add to what Craig said, first of all, I tell people do it after breakfast and then also before bedtime, because why not make it longer than 30 minutes just in case there can be the potential for increased contact time. The other thing is, because oral thrush is probably the number one side effect, I tell patients, within 5 minutes after they've either used the fluticasone inhaler or the oral viscous budesonide, just take a little water, gargle, swish, and then spit that out just to get the additional residue out of the oropharynx.
All right. Any other questions? Bennett.
Sure. So the question was to discuss just the role for dilation. I've talked about this at previous conferences, but I didn't want to sound like a broken record this time, but it is a good point. Dilation actually does have, in my opinion, an important role for treating the fibrostenotic form of eosinophilic esophagitis. We know that below a diameter of 12 millimeters, patients are much more likely to have food impaction and much more significant and frequent dysphagia. And in fact, patients who are complaining of near daily dysphagia, I can almost guarantee that they're going to have a significant stenosis. So with regard to dilation, just real briefly, I prefer the balloon over the bougie dilator. I'm comfortable using the bougie, but the problem with EoE sometimes is that there can be multiple strictures of varying degrees. And so it's going to be a lot more onerous task to start really small, and then you maybe only can dilate one stricture in a given setting, which is the most significant one. But when you dilate it with the balloon, you get to see, you can actually look through the balloon while it's inflated. If you just put a little water from the lens rinse to serve as an interface, you can actually see most of the time when the mucosal tear occurs. And that's a good stopping point, because once you've gotten the tear, going beyond that is just going to increase the risk for perforation. The other thing is to have a really good working relationship with the nurse or tech who's inflating the balloon. This is not like a Schottky ring. You don't want to inflate the balloon too quickly. That's an increased risk for causing more transmural damage. Once you reach that point of mucosal tear, you're really done. And then depending on how much you've gotten them dilated, if you want to do the dilation protocol, the evidence from Joel Richter suggests getting up to 17 millimeters or 16 and a half, depending if you're using the balloon or the bougie. The studies show that if you use that as just monotherapy, patients can go for 1 to 2 years before they develop recurrent dysphagia. But again, it doesn't treat the underlying inflammation. So, and as much as I enjoy doing the dilations, if the patient is willing to take some kind of therapy, I think that it's best to do that as well. It also, for patients who have very significant stenoses, even if I do an initial dilation, I like to have them on either steroid or PPI, because in a way it almost softens up the stricture, so to speak. It takes away the inflammatory component. It might actually make the stenosis less significant, such that either you don't have to dilate or you can actually get to a higher level of dilation, or you can do more in one sitting. So I think it's a great option, but again, just like everything else, whether it's diet or the different medications or dilation, it really does need to be individualized, and the patients just need to understand their options. And it is very safe. There's negligible increased risk of perforation. The worst or highest rate of perforation that's been described is 0.3%, whereas we typically think of the overall risk as less than 0.1% for just a standard EGD.
All right. Shout out.
So I'll also let Nancee talk about this as well, but the literature is actually suggests that it's a very poor predictive value for allergy testing. There was like one kid study that suggested maybe a 50% correlation, but really it's closer to about 15%. And so typically there's not really much of a role for allergy testing when guiding food elimination. I'll let Nancee comment anything more, but I do want to just make a plug that our dietitians are great, and this is actually a big commitment, and patients need to understand what's involved so that if they're going to commit to it, they commit to it right. So their services have been invaluable, and when it comes to that food elimination protocol, they're way more important than the gastroenterologist.
Thanks, Kevin. So in terms of allergy, I 100% agree. The research really doesn't confirm that we should be automatically sending these EoE patients to an allergist. What can be helpful is if there are already other allergens that we should be aware of. So we've had patients who came in with a known shellfish allergy or a known legume allergy, and that may help us to determine what type of EoE protocol we should be doing and what form of the elimination diet we should be doing. So that's how that can help us, but otherwise it doesn't seem like it's necessary to involve the allergist otherwise.
Anything else? Yeah.
So I believe the question, and please correct me if I'm wrong, if this is an allergy issue, why aren't we finding out what the allergy is?
Well, I think probably the pathogenesis of eosinophilic esophagitis is allergy. We all agree on that.
Yeah,
right?
I think, I hope I'm answering the question correctly. It is an allergy, but it's a different immune-mediating process than, say, the way food allergy testing is done with an allergist. Whether it's skin prick or patch testing or even serum IgE levels for different types of allergy triggers, that's not how EoE works, so that's why there is such poor correlation. They can get it done, and it just doesn't seem to help lead to a more likely source for the trigger or triggers.
And also, if a patient has an IgE-mediated true food allergy, they're usually going to have upper respiratory symptoms that are going to occur within 30 minutes to 2 hours after a meal. This is not necessarily the pattern we see with EoE. It's a building up effect, correct? And so they may eat something, be fine, and then boom, they're having their dysphagia episode. So we can talk with the patient about the differences so that they can understand how those different pathways work and what types of symptoms we would expect to see and why an allergy test may or may not be necessary in their case.
Yeah.
I saw a little bit of reference to Esophagia, but not a whole lot. I'm just wondering, how do you differentiate Esophagia from the Supragastric, both the interplay, how do you differentiate between the two?
So my personal belief is, and I think the literature supports this, is that Esophagia, if it exists, is exceedingly rare. So by far the vast majority of patients who have this belching disorder, this repetitive, rapid belching, that is almost universally supragastric belching and not Esophagia. The symptoms you get from Esophagia really are, you're swallowing nitrogen, the nitrogen is getting into the gut and they get bloated. It's not so much that they're belching.
But isn't that kind of years ago, you might have classified this as a form, and it's kind of an evolution to this what's really happening?
Yeah, that's exactly right. This is relatively newly understood, and we have to start thinking in terms of supragastric belch rather than Esophagia. Craig, do you
Because
agree?
you don't see any pharyngeal or esophageal peristalsis, so it's not swallowing air, it's sucking or pushing in the air, so that's the distinction, manometrically.
Yeah, and the speech pathology community, they used this as a way to teach esophageal speech for a long time.
Yes, the supragastric belching is a way to teach esophageal speech. We don't do that so much anymore because now we create a puncture between the trachea and the esophagus, known as a tracheoesophageal puncture, and we insert a prosthesis in there, and that now is how our laryngectomies learn to talk.
Right. Yeah.
Another question on the EoE front, we talked about the skin prick testing, but I'd seen previously talking about injecting antigen into the esophageal mucosa looking for reactions. Has that gone any further?
Be truthful, I'm not quite aware of studies looking at that, and I'm going to assume it's done by way of endoscopy. I'm not familiar with it though, so I don't want to answer incorrectly.
And the one that I've seen was looking specifically for food sensitivities and irritable bowel syndrome, and I think it's being studied, but it's nowhere near prime time.
Yeah. That's okay. Was it the squamous mucosa that had the eosinophils in it? Okay, so that's you guys want to weigh in? Anybody?
So really, so I guess a couple points here. Number one, when you're trying to diagnose eosinophilic esophagitis, you really want biopsies from 2 levels, and that should both be in the esophagus and not specifically at the esophagogastric junction. In this particular case, if it sounds like it's in the stomach side of that Z line, I don't think that I would in any way say that this fits with eosinophilic esophagitis or would raise much suspicion for me. Most likely, I would say that it's probably related to a reflux effect because it's right at the EGJ.
Yeah, Craig.
But just to say, there are other eosinophilic conditions that affect the GI tract other than the esophagus, the so-called EGIDs, eosinophilic gastrointestinal diseases. So you can get eosinophilic gastritis, you can get eosinophilic enteritis, you can get eosinophilic colitis, and we don't have the numbers like we do for EoE in terms of more than 15, less than 15, but you can get eosinophilic disorders involving, the stomach, the duodenum, and the colon, separate to EoE.
Yeah, and in some places it gets really murky, like the colon. Who knows what the right number is for an eosinophilic colitis, because there are lots of eosinophils there anyway, right? Yeah. Anything else?
I just want to throw some light into the topic. The GI tract, as you mentioned, eosinophilic involvement. It was the mucosa of the GI tract, muscular mucosa of the GI tract, and the peritoneal lining of the stomach. Peritoneal lining of the stomach. So those are 3 different entities that are described very well in the literature. I had a great opportunity to have each one of them in practice. And mucosal, muscular involvement, peritoneal involvement. So that we good opportunity to see what these patients.
Absolutely correct. Absolutely correct. Anything else?
I was going to ask one question about EoE. 6 months after I was diagnosing the patient, he never came back for follow-up. He never took the treatment. He came back 6 months later for non-specific compliance, and when we repeat the endoscopy, it was completely resolved with no treatment. So how do you follow up? What is the explanation and how do you follow this?
So I think I'll speak first. We see people who have other things, including just reflux. And some of them get subtle furrowing, like you'd see in EoE. There are some of them who get what's called a feline esophagus, which is really not the same thing as the rings that you see with eosinophilic esophagitis. It's really contraction of the muscularis mucosa causing tiny little ridges that come and go when you're doing the endoscopy. Anybody else?
Yeah, just to add, I mean, there's a differential for esophageal eosinophilia, and especially in someone who wasn't necessarily experiencing prolonged symptoms, they came back and really without any change. One thing to consider is maybe some medication that they might have been taking. Again, don't know the full history, but that would be something else. It's, I'd say, pretty rare for EoE to just resolve on its own. So whether it's changing diet or avoiding a medication, or to lead to resolution of the eosinophilia, something should have changed.
Yeah. Anything else? Way in the back. I'm sorry, guys. We're right at the end of our time. So.
So I've been seeing a lot of these types of conditions with regurg, etc., with chronic marijuana use. It's on the rise here in California, but elsewhere as well. Have you noticed more of these conditions where, like in California, because of the marijuana use, the overeating, eating too quickly, eating at night?
I mean, you guys can weigh in, but personally I haven't. I've seen a lot of patients here, like you said, use marijuana, and I have not seen an association with an increase in regurgitation or rumination or these other behaviors.
I mean,
clearly you see something akin to cyclic vomiting syndrome in those patients.
That's true. Those, or you can have the cannabinoid-associated hyperemesis. Those other conditions, can be on the rise. But in terms of like belching, rumination behaviors, I have not seen a rise in the prevalence of that.
Yeah, I haven't either. Maybe it's just my patient population. Anything else back there? No? So these guys will be happy to answer your questions at the break here. This group has made a big difference in our practice of gastroenterology in Westwood and in other places where we have practices, and we can't live without them. So thanks, guys.